All right, team, welcome to Plastic Surgery Untold. Today, we have a special edition called Bad Gas. This is including our anesthesia providers. We actually recently did a Instagram episode where we talked about some of your most common anesthesia questions. It was so popular that by popular demand, we decided to have some of our guests back and do an entire episode on anesthesia because, with Instagram, it's great, but sometimes you only get little clips. This gives us a little bit more of a chance to really dive deep into that. So before we get to our distinguished guest, Dez, let's go around the room, catch up with our celebrity cast and see what's been going on in their life. G-berto, recently somebody commented that you're not only Austin's most beautiful man, but you might actually be America's most beautiful man. Any statement on that accord?
This is all news to me. I hadn't heard that.
Oh, you don't follow us on our Instagram?
I do.
That's interesting.
I missed that part.
I also heard a rumor that you got set up on the gram. So is this a new thing of dating on the gram?
Now that I heard.
I
think I have you to thank for that.
Do we have any follow-up on this dinner date at Plank? Is it Plank that you're going to? Maybe if anybody who owns or works at Plank would like to help set up this distinguished dinner, for two, please let us know. We can maybe do a little sidebar clip to the dinner date. Any progress on this on the home front? What's going on?
So can we give them backstory just so so the public knows what we're talking about?
I just figured that they watched, but no, go ahead. You're right. Maybe one or two people missed it.
Maybe one or two missed it. So Johnny had his Tuesday session where he was talking about SkinCeutical products, and he apparently made a comment that his esthetician Anissa had, I guess, recently broken up with her boyfriend or something, and so Johnny was probing her for information about what her likes and dislikes are, and somehow my name came up in the conversation.
Because she was wanting to date on Craigslist, and I didn't know if Craigslist was the best place to meet somebody. So I was like, why don't I just introduce you to a stunning gentleman, if you will?
From someone who's tried Craigslist before, it's not a safe way to go. Let me tell you. But no, so. Yeah, I reached out to her on Instagram and
you slid into her DM.
I tried to.
Wow.
I tried.
How did that go?
Well, I never got a response.
Oh.
I was left unread.
Wow.
Wait, were you really left unread?
Yeah.
So she had her read notifications on, and yours just got scanned over.
Yeah, I guess it just.
You see that little thing at the bottom
where it says "seen."
Oh, heartbroken.
And then you see the dot, and then no response. You're like,
it was never seen.
Swing and a miss.
Okay.
Swing and a miss.
Okay. Well, so, but then you didn't let it go, being the gladiator that you are.
Well, no, I'm a man.
So what'd you do?
So I went to your office and I told her in person.
And what'd she say?
She was like excited and giddy, but I don't know.
Well, she was cornered
at
that point.
And then she ducked into her room.
I think she got a little nervous. She's redhead, right? But her whole face went red too.
Wait, hold on. You didn't even know who she was?
He had to ask her for directions at the front desk.
You just hit on any woman in the office, like, hey, girl.
What's up?
Like I said.
You free? You free later?
Just go down the line.
You got to shoot your shot, Donald.
Hey, man, I hear you.
We wish you luck. You got to keep us updated, and maybe the next episode we'll hear a little update.
We'll need the post game breakdown.
Yeah, maybe
Okay, cool. Celebrity Anesthesia. Over this time, some people have asked where the name Celebrity Anesthesia came from, and whether. And I know fact or fiction is typically later in the day, but fact or fiction, are you really a celebrity? Because this is starting to come into question by some in the community, if you will.
All right, that's fair. So
we're just trying to keep it real on the show.
I would say that I'm not a celebrity, but my wife is a bit of a local celebrity, and I actually have you, I believe, to thank for the nickname originally. It started with me having a celebrity wife, and then me being celebrity husband, and then that turned into
that's where it started.
That turned into me being Celebrity Anesthesia. So, and then my partner and I were, thinking about business names, and I was like, man, who better to do your anesthesia than a celebrity? So we landed on that, and it stuck. So thank you,
Fact Finders,
Dr. Franco.
This evolved from Celebrity Husband, which yours truly started.
Yeah, you did. Yes.
You're welcome.
You're
welcome.
That was
Celebrity
a circle,
Anesthesia.
just to go back to him.
That's exactly
what it
right.
was.
He
Just-
self-plugged.
I'm just trying to keep it as real as possible.
You're,
here.
you're making everybody's lives. That's what you
You
do.
know, just
you do.
anything else you want to catch the world up on in celebrities' life now that we know the truth of what's going on here?
Well, my celebrity wife at Your Trendy Therapist,
There
give
it
her a
is.
follow. Shameless plug number 6012. She was in an accident 2 or 3 weeks ago with an 18-wheeler. She is completely okay now, but her car was totaled. It was a hit and run accident. It was actually super scary throughout the entire process, but she is okay. But that meant that her car was totaled and we ended up getting a new car. So exciting times at the Osborne household. We just got a new whip.
Can we save the new car for a little bit later? Because
Yeah.
we can't give all the nuggets
Yeah,
away.
can't give them all away.
Okay.
And the Lambo only came in one color. So.
Jeez.
Tall gamer, what's going on? How come you got the little seat?
I don't know why I got the little seat. Like
We
I'm,
actually tried to put him in a different room, but it was too difficult.
biggest person on the cast and the tiniest seat.
Big
like
birds
I might
on the smallest perch.
I might fall over during this.
Well, let me know. A lot of big things happening in your life.
Yeah,
correct?
man. So just relocated from. So if anybody knows the area, I used to live in Hutto, but now I'm living in Austin proper.
More
So-
importantly than your home location that you're trying to give out to the world, can you talk about because they're not bringing you a housewarming gift if that's what you're asking for.
I
But
don't need any
second,
more
can you-
warming at the house.
Can you let people know? Didn't you release a new game?
Yes.
Oh, you forgot?
Yeah, no, I was going to get to that. Come on, man. It's been a busy time for me. So, part of the reason why I wasn't on the last couple of episodes is because I was dealing with the game release, which is Ruby.
That's
Grim
what we
Eclipse.
told him.
Yeah, yeah. It's the Ruby Grim Eclipse, the definitive edition for the Nintendo Switch. So that was like a 6-month long project, 6 or 7 months long, and like immediately as it shipped, I started up 2 new ones, and so some big reveals coming up in the next month.
That's awesome, man.
Yeah,
Congratulations.
So it's a bunch of huge stuff going on in my world with all the games that I'm getting to work on. So it's crazy.
Very cool.
I mean, I'm super excited to try out the samples that he brought us.
Oh,
I mean,
yeah.
this is,
Me too.
I can't
yeah.
wait.
No,
I can't
awesome.
wait. I'm ready to
You
play.
joke, but I have
boop,
keys.
boop, boop,
You,
boop, boop,
you don't
boop.
have a Nintendo Switch.
You don't know what I got at home.
I've been to your house.
Can we get? And so on that note, and moving on to
I
our
thought we were getting switches with the game.
yeah, as we should, as we should. Well,
Wow.
Des, catch us up a little bit about you, what you do, and why we have you here on this episode, special edition of Bad Gas.
Well, thank you guys for having me. I used to work with Travis. And also I knew Travis back in North Carolina in a previous life.
It's
Back when we
true.
were both
This
in
is
school
true.
for anesthesia. So it was really wild to find out when I moved down here to Austin, I was gonna be working at the current location with you, of course. Looking at the name, like, man, could it be that Travis Osborne? And sure enough, he comes busting in the door one day with a coffee in his hand. He's like, I had to bring this, man. He's like, I know you. And I'm like, I know you. And it's just wild how small the community really is in the terms of nurse anesthetists.
Yep.
I mean, 40,000 in 50 states. I mean, probably about, maybe
Now-
1,000.
Back then, when you knew him, did he wear shirts back then?
Yeah, he was a little smaller back then, I do believe. He wasn't doing as many push-ups, so he did wear shirts. I think the ORs really frown on you being shirtless. So, but nowadays, man, it's
chilly.
just too good to have a shirt on.
God,
Yeah.
y'all are killing me.
He's handsome.
And,
He's a handsome man.
Tell us a little bit, Des, about your practice, because for people that are just tuning in for the first time, one, shame on them, but two, you specialize in plastic surgery, aesthetic surgery, because that's basically 90+% of what you do in terms of your anesthesia care you provide.
It is, yes. I work at a plastic surgery center that pretty much wheels and deals, actually probably about 100% in plastics. I started out in trauma, neurotrauma. I loved it. Moved to Texas, kept doing it, and I said I wanted something new with my life, and was very lucky and fortunate to be able to land this job because it is a highly coveted practice in the realm of anesthesia and plastics. Everybody wants to work in there. And when you finally get that taste for it, you're like, wow, man, it is nice to have those ASA ones, very healthy. But on top of that, you really get to start knowing the patients and the surgeons that you work with, and you just like fall in love with like being there and really making a difference in not just young, a little bit older people's lives, being able to see I've had these changes in my life and I can't wait to make this change for myself. Especially some of these mothers where you do these mommy makeovers. It is remarkable to hear their stories and be like, wow, that's this journey that they go on. And like, I finally get to do something for myself. I'm so excited for this change. So it's nice to be a part of that.
And one of the things I'm super excited, the reason we want you on the show is both you and Celebrity have been super aggressive in terms of trying to evolve anesthesia care, especially at our surgery center. And we've done some other things in terms of, ERAS and preoperative medication. We've changed some things, and I say we, mostly you guys, in terms of the medications and things that people get during surgery. And we might dive a little bit into that, not to get too lost into the weeds, but into a little bit of that later. And then recently we were even talking about some blocks, like PEG blocks, tap stuff, other things that we do. And we talk about it. The patients are typically asleep for it, so they don't even know. But stuff that we're going to provide care. And just the two of you have been very, very, I would say, on the forefront of trying to like push and make some of the stuff better. Some of the stuff's relatively new, some of it's not, but some of it's with technology has become easier to incorporate into a surgery center where people are going home the same day and other things. And it's all in the purpose of making the experience for the patients better.
Yeah.
Completely agree with that. I mean, I think me and Dez share a very similar philosophy in the sense that, it's outpatient surgery. And that's, I now am not 100% in cosmetic elective stuff anymore, but it's still a large part of my practice. And a lot of what we do at Celebrity is outpatient day surgery. And it's about getting patients out quickly, about making sure that they're comfortable, about decreasing their, narcotic requirements and making sure that they feel nice and lucid and comfortable post-operatively. And I think we both kind of champion that cause because it makes a big difference in those patients' immediate post-op recovery. And even, 3 or 4 days later, when they come see you in the office, they are more refreshed. They feel better. They're better hydrated at that point. They have better pain control. And really, I think that's because of what we're doing in the OR.
Can we be a little systematic and maybe go through a few of the basic stuff and then we'll get to the good part? Maybe just if you guys can tackle a little bit, because I think it's sometimes confusing when we talk about anesthesia. We use this term a little loose in general, but within that, there's some subcategories. There's local anesthesia, something called MAC or managed anesthesia care, and then general. Do you want to give a quick little cliff notes of kind of that spectrum where you guys fall in and kind of what's relatively done under each of those episodes?
Yeah. So I like, when I'm talking to patients, I like to basically outline 3 types of anesthesia. There's general, there's regional anesthesia, and then there's MAC, what you alluded to. And sometimes.
What about local? Are we a redhead step down?
Local is regional. Local is technically regional anesthesia.
Okay, he wasn't paying attention.
You're localizing a region of the body, or you're anesthetizing a region of the body. So with general anesthesia, that's where you are completely to sleep with either some type of advanced airway, whether that's a breathing tube that goes down into your windpipe, or a supraglottic or above the vocal cord airway that sits behind your tongue, keeps your airway open.
Love the fancy words.
Thanks, man. I studied all night for this. So either that or the other option we talked about was regional. That's if you've ever had a C-section or an epidural done, you had a spinal block placed in your back, or you had that epidural placed in your back. Those are types of neuraxial or regional anesthesia where we localize or anesthetize a region of the body without putting you completely to sleep. We can also take, that same type of anesthetic, and we can do it in certain areas. Like Dr. Franco was talking about with local anesthesia, those local anesthetics bathe those nerves and stop nerve impulse from going and propagating back to the brain. So basically,
for like scar, we do those for like little scar revisions,
exactly,
little touch-ups, which happen. You can't have an 8-hour surgery and not have some tiny little touch-up stuff. And I always tell people, it's not going to make everything completely go away. It tends to give people more of a sensation of like when you fall, your arm falls asleep. So you're going to be aware of people touching, pushing, but there shouldn't be pain.
Exactly. I always tell patients you're going to feel pressure, but you shouldn't feel pain. If you feel any pain, we can always put in more local anesthetic to really bathe those those sensory nerve roots that are around the skin, because that is typically the most sensitive portion of making an incision or having anything done. And then it bathes those nerve roots and renders them basically numb, if you will.
And this is something where sometimes you see, people get into trouble with local anesthesia when I think it works great. It's a great tool. We use it in conjunction because I know we're talking about to simplify it kind of separate, but
Sure.
they tend to merge a little bit, and
Yep.
maybe we'll get into a little bit of that. But local has its time and place because, like anything, too much of a good thing can cause problems too. And I think we've all seen things in the news where people get too much local anesthesia, and sometimes that's when you're trying to do too much of this.
Yeah, I totally agree with that.
Totally.
The local anesthetics, there are several different kinds that we use. Each local anesthetic has a specific amount, milligrams per how much you weigh, that is a safe dose for you to get before you start to show any signs or symptoms of local anesthetic toxicity. And what we do as anesthesia providers, we know those values, number one. Number two, you and I have those conversations before the case. Hey, this patient's only 70 kilos. We're going to need to reduce that local anesthetic dose so that we don't get close to that patient having a local anesthetic toxicity. And then we're also monitoring the patient throughout. So we would see changes to their EKG rhythm, different sensorium that the patient may have, and tell us like, hey, I'm feeling lightheaded, I'm feeling dizzy. We would know those things. And then the last one that I hinted at was MAC anesthesia. Dez, you want to talk about that a little bit?
Yeah, MAC or monitored anesthesia care. It could even be a spectrum within itself
Totally.
as to what we can do for a patient. And that's really where they're a little more awake in terms of, you could do like with cataracts, they're a little more awake. You don't want the patient kind of jittering, obviously, while you're that close to an eye. And you can use that in other types of anesthesia.
A lot of times when we do colonoscopies,
Yep.
or things that need to be done in the office, procedural sedation, sometimes it's referred to, or sometimes it's referred to as twilight anesthesia.
Yeah.
But it's basically giving patients a little bit amount of sedative medication to make them sleepy. And like Dr. Franco said, sometimes we even use that with regional or local anesthetics combined.
How does that differ from like conscious sedation, or is that just a synonymous term?
It's kind of synonymous. Again, we're kind of in this massive gray area, right? If you give somebody more than a conscious sedation dose, that's technically MAC.
Mm-hmm.
But MAC is when an anesthesia provider, either an anesthesiologist or a nurse anesthetist, is by your side, making sure that you're safe during the procedure. In Texas, I believe RNs can do conscious sedation, but again, that they have a very limited scope on what they can give, and it has to be prescribed per the surgeon or the doctor that they're working with.
I think that's a good stepping stone, and I don't want to again get lost too, because it'd be a whole separate conversation of who can provide anesthesia.
Sure.
And again, it really comes down to it's different from state to state. Also, too, depends on what anesthesia that we're talking about, because
Absolutely.
local anesthesia is injected by a lot of providers, surgeons, primary care physicians. Again, if you're doing a little scar vision assist, a lipoma removal, Gilbert, you tend to do a lot of local anesthesia procedures in your office at a dermatology clinic, and biopsies, other stuff, because
Biopsies,
not everybody
excisions.
needs general anesthesia. I mean, we don't want Celebrity just sitting on a yacht. No, he's got work for it.
Yeah. No, so we do a lot of minor procedures in my office where we use local for biopsies and excisions and things of that nature.
Because you guys don't do any type of anything above the actual local anesthesia.
No, not in our setting.
And correct me if I'm wrong, but because we used to do it when I did more biopsies and other things, is we would limit the amount of areas we do in one setting to avoid some of the problems that Dez and Travis have talked about in terms of too much anesthesia, and then also just from a comfort level. At some point, you can only lay there so long being still.
Yeah. Plus, it helps mitigate the risk of like skin infection and stuff when you're doing too many things at once.
Mm-hmm.
Definitely agree with that.
And then kind of marching down the road, regional stuff. We've talked about it. There's some people who have been specialized trained to do some of the more advanced regional techniques. And that was one of the trainings you guys hosted for some other providers a couple weeks ago. And that was pretty fun. That was interesting. It was great.
Yeah. So one thing that, we talked about a little bit was regional anesthesia. So I talked about that epidural and the spinal. We do those for laboring parturients or mothers that are about to have a baby, and we can block basically either create a band of anesthesia with an epidural, or we can create a level of anesthesia down all the way to their tippy toes with the spinal. But we can take that same principle and we can actually go to different parts of the body. And under ultrasound visualization, we can look and find where those nerves are, and we can inject that local anesthetic, and it will bathe that nerve under ultrasound. And once it sits near that nerve and bathes it completely, that actually renders that nerve numb, for lack of a better word, from there distally. So those patients, like for shoulder surgery, I used to do a lot of orthopedics when I was in Arizona. We would do an interscaling block, a single injection with 15 cc's in the patient's neck, and it would make their arm and their shoulder completely numb. So when we did their general anesthetic for the case, they'd wake up and they would not have any pain, and they would wake up with no pain from the procedure. Pretty cool stuff that you can do with local anesthetic.
It's just amazing how much this stuff has evolved.
Yeah, it is. And it's really wonderful. Like we said, there's a whole big like kind of dome of what falls under anesthesia, and being able to use both in conjunction with each other, a regional with a general anesthetic. So we don't have to give as much narcotic, which is really great for them waking up. Not only that, having those regionals with, putting long acting local anesthetic in there, the patient can get up and move around a little bit quicker, which we want. We want to promote. People think, oh, I'm done with surgery, I'm gonna lay in bed for like 3 days. No, we don't want that for you. We want you to get up. Those are gone.
They're gone.
And we're able to give them that opportunity to get up, and patient like, wow, 3 days later, I still feel great. And it's really nice to give that to the patient, to get them up and moving around and get them back to their kind of normal daily.
So I got a question between the both of you. Obviously, you guys have similar education, coming from the same schools and things. Are you the same? Like,
wow. Ooh.
Not as in a
Are we
competitive
equally
level.
as good? Is that what you're
Now,
asking?
one is celebrity and one is average. And
Yeah.
No, actually, so no. I really wasn't going there. But like, I mean, as far as provider level, like, or is there anything?
Yeah. So no, we're on the exact same level. We are both nurse anesthetist, and in anesthesia, in general, there are anesthesiologists, nurse anesthetists, and then there are certified, I guess, anesthesiologist assistants. But basically, I'm much more familiar with anesthesiologist and nurse anesthetist. So these are the two that I can probably speak to the best. But for lack of a long answer, we basically took different roads to get to a very similar endpoint. We are both anesthesia providers, we're both anesthesia experts, and we can both provide anesthesia care on our own for the patient, with the surgeon. So to answer your question, we do the exact same thing. We have the exact same credentials, and we provide anesthesia services.
Okay.
But it's similar to, if you think about like surgeons, because there's, 60 plastic surgeons in Austin, but, while we have the same credentials, doesn't mean we do the same procedures,
That's
different
exactly
stuff.
right.
There's things that people specialize in. So I think that's a really big kind of question and stuff. It's hard, but they both do a phenomenal job for us.
I really wasn't
Thank
trying
you.
to like.
Thank you, Donald. Thank you, Donald,
I knew where you were
for
going,
pot stirring.
but very similar to like G-berto. You do a lot of facial aesthetics and derm practice PA stuff. There are other PAs that are in other practices that don't even touch a face.
I can
So
also
even though they
attest
have the same,
that he does not use any numbing or any kind of patient help on
Most
that.
patients are a little bit stronger than.
yeah,
I just
Yeah.
just know.
And then, one of the questions to kind of start getting into some of the questions that I
Sure.
get all the time. One question that I get all the time is like, who decides what anesthesia I need? Or do I need, general anesthesia for all my plastic surgery procedures? Again, all plastic surgery procedures is a broad term.
Right.
And so there's a certain set of procedures that we've kind of already decided are very good. Patients in general are
Yep.
better suited with a general anesthesia. And again, we're just talking about our standard patients that are healthy, no medical problems, that have passed all of our screening tests.
Yep.
Yeah.
We're not talking about outside stuff
Outliers.
that are typically going to be done at a hospital or stuff, things like that. But a lot of it depends on different factors. We'll communicate, but I mean, maybe you guys can talk about why, for like BBLs where people are going prone,
Sure.
Maybe breast augmentations where we're under the muscle, why general is probably considered the standard, at least in the United States.
You want to touch this or
Yeah, I mean, you talk about who decides. We all kind of decide together. We have our conversations. You can even have your conversation with the patient. Hey, how do you feel about this? Patients, in the grand scheme of things, it's all about them. It's about their comfort level. And I've had patients all across my travels that I can't have this certain type of anesthetic. I don't do well with it. I am very overwhelmingly anxious. I'd rather go completely asleep. If a patient tells me they'd rather go completely asleep, I'm going to honor that for them. Unless I really deem that maybe there's another route that we could take, and
or a medical
gotta-
reason that
Yeah,
that we
or
that's not-
exactly. Like I would prefer if we can do, a regional or a local. Or a MAC. Let's try that. And it's all about communicating with your patient, being able to let them know, hey, like this is the best outcome for you going that way. And especially with procedures where you're going into the muscle, or a BBL where we have to go completely prone or face down, where we need to protect your airway and protect you. That's why we need a secure airway to be able to provide the best anesthetic.
I completely agree with that. And one other thing I want to add is there's this misnomer, I think, in society and in media, and it gets overblown all the time, that somehow it's safer to not have general anesthesia. And
you took my next question away.
And
Because I hear that all the time.
Absolutely.
I'm always like, depends.
Exactly. So let's take a BBL, and pretty much globally, you, me, other anesthesia providers that you work with, we all pretty much do all of your BBLs under general anesthesia because we believe it's the
and not just my BBLs, all the BBLs that are done at your center for the most part.
Exactly. And everyone that I do BBLs with besides you completely asleep, and we do them under general anesthesia. And again, I think that's because I truly fundamentally believe it's the safest way to do that procedure. When we do those patients prone, or when they're on their stomach, if we were to anesthetize them with any type of sedation, we could potentially make them stop breathing or lose their airway or start to obstruct while they're breathing. And if they're prone, or if they're face down on their stomach, how would we rescue their ability to breathe? It would be almost impossible to put an advanced airway in. It would be almost impossible to jaw thrust them, or to do something to open their airway and to get them breathing again if they're already prone. So we place a breathing tube at the beginning of those cases and run them on general anesthesia the entire time, so that we're able to turn the patient. And when we do turn that patient, we have a patent airway throughout with a breathing tube. And a lot of people, I think, especially during COVID, they took being on a ventilator and having a breathing tube to be synonymous with you're not going to wake up, you're going to die, it's going to be terrible. And those in healthy patients are not a huge risk. We place them every day, all the time for quick cases, and then remove them at the end of the case when the patient's breathing on their own. So that's standard procedure and standard protocol for us. It's just a lot of lay people are not exposed to that on a daily basis.
Because I always tell people, once you guys get the tube in and secured, that's as safe as they can be.
That's exactly
whatever's
right.
going on, you guys can control that. You
Exactly.
can take care of. Again, leaving out the extreme cases, you guys are going to take care of it. You're going to breathe for them. I mean, that is when they are most secure and safe, is once you get that tube in and secure, because you can do whatever you need.
Absolutely.
And another thing I always like to tell my patients too, because that's the next question that comes up. Hey, we're going to go all the way to deep sleep. I'm going to place a little breathing device for you, whether it be an LMA or a not subglottic, supraglottic airway device that doesn't go through the vocal cords. You will not be awake when that happens, because that seems to be a real fear of being like, am I going to be awake when you put that breathing tube? Absolutely not. You are going to be completely asleep on both ends of the spectrum. You're not going to remember it went in. You're not going to remember it comes out. You're just going to wake up and you're going to be like, oh, wow, it's already over. And then I'm like, I'm sorry, your nap wasn't longer.
And then do they ask you right after that, will I wake up during the anesthesia?
Yes and no. I mean, I'd probably say half patients I probably hear it from. And people who are more experienced, they've had anesthesia or a handful of anesthesias in the past, they know what's going to happen. But for those individuals, it's their first time having anesthesia. Oh man, the questions, the anxiety kind of takes hold, and that's completely okay. And again, it always comes back to communication. Hey, let's talk to them. Let's have a quick conversation. I want to let you know every single thing that's going to happen while you're under my care, so you don't have any surprises. And usually once you have that conversation with them, they feel so much more alleviated by that. And they're like, okay, let's do this.
So let's go through some of the questions, because I feel like we've gotten a good kind of general foundation to get started. I think we started to touch on a little bit. Will I wake up during anesthesia? I feel like you guys have answered that. No.
The answer is no, especially with the general anesthetic. If you are having sedation or that MAC anesthesia, I always tell patients when we're doing a sedation case, again, this is not general anesthesia. When you're having a sedation case, I always tell them, hey, you could kind of wake up and kind of go in and out of consciousness. You could hear us moving around in the room and hear us talking a little bit. but I'll make sure that
Probably
you're.
the worst part hearing our jokes.
That's exactly right. That's more painful than the procedure.
My arm doesn't hurt
Yeah,
just
exactly.
listening to this. My
Your
head
jokes are
pounding.
terrible. But for general anesthetics, no, you're not going to wake up during the case.
Des, any comments to
Oh,
that?
I completely agree. Over the
Because we
course,
brought you here to fact check celebrities. So,
That's literally the only
rule
reason
number
I'm
one.
here.
He uses a lot of big words, as you can see.
He's a well-educated man. He went to Duke for crying out loud.
He doesn't let you forget.
God.
No,
I really thought that was going to come up when you're asking if you guys were the same. You're going to be like,
Oh.
well, I'm a Duker. He's a pirate. Boom, boom, boom. Just,
I wasn't even going to touch on that, but
I have to go there. Over the course of the past few decades, how many monitors we are able to use. I mean, if you were to actually look at our machine and see all the numbers we see, it's so funny. I'll take a picture and send to my wife, and she goes, "Oh my God, how are you able to look at all that and know what's going on?" I'm like, I could tell you what number is wrong out of the dozens of numbers that we see immediately, because we're trained so well throughout school to be able to notice that we know when there's something different than what we started. And it's all about anticipation, making an incision. I'm going to give you something to make sure that blunts that response.
And that goes back to having that great working relationship with surgeons like Dr. Franco that, we're working with on a regular basis. You get their routine, you know what kind of surgeries they're doing. You are just as involved. Like, I'm standing up during the case, like over the drapes, we're talking back and forth. If we know that something's going to be a little bit difficult, or, we're going to get into an area that could be a little bit more painful, I'm anticipating that. I'm already giving medications to pre-treat that while he's doing his thing. And it allows him to be able to focus 100% on the minutia that he's focused on, closing a wound or opening something up, so I can just do my job and he can just do his.
I think that's a great point in terms of safety. You guys hit on both of those. One, you're focused on a million things, and you're listening to the monitor, you're watching everything, that it's going on. So I can be 100% focused, whether it's that breast, tummy, butt, whatever it may be. And I'm not worried about, and I don't want to say I'm not worried about the patient overall, but you guys are taking care of that at 1,000 different ways. And it's not just checking the monitor, checking their heart rate stuff, because every time we position, it's another check. You guys are always under the drape being like, hey, let's make sure there's no pressure on their nose, make sure there's no, the shoulders are good. There's nothing on her hands, that they're not being overly extended. It's so many little things throughout the course of the day or that procedure that I think sometimes becomes like unsung heroes of the surgery.
Well, totally. Because when you have a patient that's under general anesthesia, the anesthesia is truly the number one patient advocate at that point. We have to speak for you when you can't speak.
I'm a patient advocate too.
You are 100%.
Thank you.
But
Celebrity.
As far as positioning goes, like, we're checking the patient constantly, and like we're just constantly doing this like sweeping monitor of what's happening with the patient, what's happening with the patient's monitors and their vital signs. Like, it's just this constant picture and new information that we're synthesizing over and over throughout the case that allows us to take care of them.
Knocked it out of the park with that
Boom,
one.
boom, 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 boom. Going down the line, another question. You guys have already talked about this a little bit, because there's kind of a spectrum of general anesthesia. Because somebody asked, do I always have to get a tube when they get general anesthesia? And I think you guys have already touched base on that. Not necessarily.
Not necessarily. I would say if you are going to be, if we need to have the patient completely paralyzed for the case, meaning that we're going to make several turns in positioning, we're going to, we need the muscles relaxed so that you can close the belly tighter during that diastasis repair of the tummy tuck. Things like that require a breathing tube, because if we paralyze the muscles in your stomach, we also paralyze the muscles that help you breathe, or your diaphragm. So when that happens, we have to breathe for you on the ventilator during that procedure. Again, this is all very standard stuff. We do it multiple times a day. And in anesthesia, this is not something out of the ordinary at all.
Here's a good question for you guys. What can patients do prior to surgery to make their surgery smooth from an anesthesia perspective? I thought that was a great question.
Well, usually, I mean, now being in the realm of plastic surgery, I mean, most of these patients are so healthy, you really don't have to do much. When we have that conversation, I mean, I guess, no, don't smoke. I think that any medical provider would say that, because obviously when you smoke, you put your lungs and airway at risk for a reaction to some of the anesthesia gases. And most of our patients are pretty good. And you'll have the conversation, hey, if you can, probably a good idea. Don't smoke. Or
there's some procedures from a plastic standpoint. You
you'll be
canceled.
canceled. But I mean, Other than that, I mean, for the most part, I mean, we could talk about patients I used to take care of who are considerably, a little,
But I
a little
think
more.
being
But
honest, because
yeah.
if there's medications
Yes.
you're taking, if there's something, and it's beyond the scope of what we could talk about in 10 hours in terms of drug interactions from different
Sure.
medications
Yeah.
and stuff. And you guys know these. We don't expect the patients to, but as long as we know everything that's in your system, everything you're taking, we can act appropriately.
Yeah, I would say from a how can they prepare or prepare themselves for anesthesia. Good diet and hydration habits for the week leading up to surgery. Not drinking for at least the week leading up to surgery. No other no other extracurricular drugs on that week leading up to surgery. Again, I'm not the cops. I don't care what you do in your free time. But when we have that conversation in pre-op, I need to know if there are any other drugs or medications that you are taking on or off label, and if they are or are not yours. I need to know what you've had, because meds that we give can interact with other medications or street drugs that you've taken. And again, I don't care from a right or wrong perspective, but I need to know so that I can safely take care of you during the procedure.
To allude on that, yeah. Again, you're going to get tired of me saying hearing communication. It really is just communicating, and to let the
Totally.
patients know we're here for you. Again, like Travis says, we're not the cops. I don't care what you do in your spare time. Especially with marijuana, I see vape a lot, and I'm like, do you vape? Is it tobacco? Is it marijuana? Because your body starts to upregulate your receptors
For sure.
based on certain drugs you take, and it might require more anesthesia from us. So if I know that beforehand, I'm like, they're probably going to need a little heavier dose of anesthetic, which is completely fine. Just let us know so we're not being
So-
surprised back there.
Yep. And the other thing, to touch on the marijuana and the vaping thing, whether it's vaping marijuana or tobacco, vaping is not completely benign, right? It does disrupt your airway. I've had more of a problem with patients that have vaped than patients that have smoked sometimes. And what it does is it just creates an environment of hyper airway reactivity. And for us, if we are instrumenting your airway in any way, either placing a breathing tube or placing some advanced airway device, it can cause you to produce a lot of mucus, to bronchospasm. Like, it can cause things that we don't necessarily want. So let us know those things ahead of time. There are things that we can do to dry up your airway, to kind of open you up beforehand. And again, that communication and honest communication back and forth just helps us to tee you up as best we can to hit a home run for your anesthetic.
Okay.
So this is a question that's coming up on the list that you had spoken about earlier that I'm like super interested in, is like, when does it wear off? And how do you plan those things? So like, if I do go in for like a shoulder surgery and I wake up, I'm gonna have about 2 to 3 days of like no pain and gradual pain and soreness. Like, how does that work?
Well, I mean, it all depends, again, what type of anesthetic you had. If we did decide to put a block up, like if you did a shoulder surgery, or for women who are doing breasts, everyone's built differently. I wish I can give you a ballpark, but even that is still, I'm just kind of
big
throwing it up in
window.
the air. A
It
big
could
window.
you could have 4 hours of pain relief, depending on the local anesthetic, to up to 72 hours of pain relief. And again, I think with local anesthetics, it's not total pain relief, right? So, and I think we've got to get that established across the board. If you have surgery, you're not going to, if you start your morning and you're a 0 on the pain scale, my least favorite thing in the entire world, the pain scale, that's a whole nother episode. But if you start your morning and you're a 0 out of 10 pain wise, when you leave the operating room after your surgery, there is no way, I don't care how good of an anesthetic I give or someone else gives, we're not going to get you to a 0, right? You're going to have some discomfort there. You're going to have, you just had surgery. So, and when those local anesthetics wear off, it's not like you go from 0 to 100. It slowly eases off over time. And like all of a sudden you start to realize, oh man, my shoulder is a little bit sore. Oh, it's starting to hurt a little bit. And then we just talk about, loading other medications when you do get
That
home
gap
to try to
wearing
bridge that gap.
And that's where some of the stuff, we've talked on previous episodes about ERAS and getting people started on stuff ahead of time to ramp that up, having a good plan and protocol for afterwards.
Absolutely.
Even some of our patients that have been involved in pain management clinics and stuff, we typically engage that provider, because as Dez, alluded to, if people have to take medications for other medical issues, sometimes they have a little bit more high tolerance, which is fine. We just want to be prepared and deal with it.
And-
The other thing I want to touch base on, you guys, in terms of prepared, and I feel like we work pretty well together, is sometimes people do have some other medical issues, may have been stuff that's resolved. A lot of times, if there's an issue, we'll have you see a hematologist, especially when it involves the heart, cardiologist, get a clearance. And that stuff we share with you guys as well, because again, it's a team game of making sure that we're all on the same page about what's going to be safe going forward.
Exactly. Yeah. You have some of these patients who are maybe a little bit older or maybe have an underlying heart condition. It'd be nice to get an EKG or get a cardiac clearance. And you're great about giving us a heads up. Hey, I have this patient. I have all the paperwork you need. I'll leave it, on the chart when I get in, and, we'll have that conversation, because it does help us out, because that does change what we plan on giving our patients. Because again, it all comes back to making sure they have the safest anesthetic possible and what is the best route to go forward for people who might have a little bit of a weaker heart muscles where we can't give them, propofol, which may really kind of blunt that cardiac effect. We might have to give another type of medication to get them off to sleep. And it's just great having that, close relationship with people you work with on a weekly basis to be like, all right, we're on the same page. Let's do this, because we could still provide for that patient who wants to have that surgery.
And I think the biggest take home there for patients or prospective patients that might be listening to this is have that real upfront, conversation with your provider, with your surgeon, right? And if they have any questions, or if they ask you to go have some of these taken care of, get on that. Go to your cardiologist, get that clearance. We're not just asking you to do it for our health and because we want you to go out and spend extra money. It's because we want you to be as safe as possible when we put you to sleep, when you're having your recovery period. All of those things are very important to make sure that you're safe enough to perform surgery on.
Well, and I tell you, the last thing they want is for, to not do some of that stuff. You guys come in, and you're like, hey, I don't know that this is a safe procedure for you. And then now we're sending you somewhere else because we haven't got an EKG. We haven't gotten a stress test. We haven't gotten these things to make sure that you're ready to go. Nothing that I personally provide has to be done that day. And so, a lot of these things are just trying to make sure it's as safe and smooth, because that's all of our goals, is to make sure that this is an incredible experience.
Totally.
And as safe as possible.
Absolutely.
Yep.
And so I feel like this is true, and G-berto can fact check us on this, but no one in medicine likes surprises. And if you surprise people, that's a good way to get yourself canceled.
Yeah, absolutely. Absolutely.
And again, what makes our job, easy on us is the preparation and work that you actually kind of really help us with in terms of getting your patients teed up for surgery to be taken and going forward. So, I mean, you have a big part in the way we're able to provide for you too.
We're a big team.
Yeah.
Go ahead.
I was just going to say, what about, not to get off topic, but what about like certain patient populations? We talked about how anesthesia affects people and how you dose it based on their weight and stuff. But does it affect people differently?
Oh,
like
absolutely.
Do some people require more?
Yep.
Or,
I mean, just and we talked a little bit about it in our little Instagram live deal the other day. Redheads actually do require more anesthesia than the average bear typically. And I think it's like 19 or 20% more anesthetic requirements just because you have red hair.
Really?
Is that because it wears off faster, or they just require more?
They require more, and they have guessed, and it's a bunch of hypotheses on like how and why that happens. But I think it's the melanocorticopin one.
Yep, there's a mutation in it that actually produces more pain for a given stimulation versus a dark-haired individual. So yeah, just seeing a patient with red hair, right off the get, you're gonna require a boatload
ramp
more.
it up a little bit.
I'm a Gucci one time.
right. But and it's not that cookie cutter across the board. We really just evaluate each patient as they come in. They may have certain comorbidities that would require more anesthesia, or maybe they do burn through medications slightly quicker because of medications they're on at home are enzyme inducers in their liver, things like that. So, it's not quite as, I love when we're at dinner parties or we're having conversations, people are like, so how do you know exactly what I'm like? Do you have 3 years of your life to sit down? Because I can go on and on and on. It took me a while to learn all this, and Dez in the same boat. So it's not like all this stuff is super cookie cutter and straightforward. There's a lot that goes into it behind the scenes.
Which makes it so fun.
Oh,
Yeah,
totally.
yeah.
Yeah, I'm right
And
there with
it's
you.
other things, like another one of the questions is post-op nausea. That's probably one of people's biggest concerns. And there's a lot of different things you guys do depending on the procedures being performed, depending on the specific patients. During the IG live stuff, you guys discussed some of those risk factors and also some of the things that you guys can do. And there's some new medications out that have made it better too. There's also still some oldies but goodies.
Oh,
Yeah,
absolutely.
Yeah, you know, we talked about those risk factor today, and I could bring them up. I talk to those patients and I let them know, you know, you're in the high risk category for most of the patients we do. Young, healthy, non-smoking females. All those factors play against you. But our role is we don't want you to have to ask for some type of nausea relief. We want to make sure it's on board beforehand.
Yep.
And there's so many great medications that are coming that are out, and there are some that some don't know actually produce a type of anti-nausea effect that we can give them throughout the case and beforehand. A lot of surgeons, including yourself, prescribe medications to take the day of surgery before we head on back. That really helps alleviate that, because there's nothing worse than waking up feeling sore and then feeling, you know, nauseated, especially after an abdominoplasty where, you know, things are really tight and you're kind of.
yeah.
So we want to make sure that you wake up and you're like, how you feeling? They don't have to ask about it because it's already there on board to help them out.
And I have buddies that, you know, I used to do, cardiac and thoracic anesthesia a lot. And I have guys that I used to work with. They're like, oh, dude, you're selling out, man. You're in plastics now. It's all the easy stuff. And I'm like, honestly, it's just different. It's a lot more finesse. I'm much more keyed in on my opioid requirements, my nausea prophylaxis. Like, yes, I haven't transvenously paced anybody in the OR, knock on wood, during a breast dog, but it's a different set of challenges. And the way we approach that, we all approach that with that same level of care and consideration that we would when I put a heart to sleep that has very, you know, low reserve. So, yeah, we take it all super seriously.
Absolutely, yeah.
Any more? We're running down on time here. Any other big nuggets, questions, common questions that you all hear? G, anything that you'd like to drop on everyone? Any comic other?
I'll let
questions
you
that we've
drop your
missed?
nugget first. You can go ahead.
No, I was just gonna say, I get from patients all the time, like, what do you do once I go to sleep? And I'm like, what do you mean? What do I do when you go to sleep? I sit there with you. I'm in there the entire procedure.
reading a book.
Like I'm back and forth with, you know, Dr. Franco or whatever surgeon I'm working with in that room. And we're talking constantly about what's going on during the case, what's happening next. I'm constantly evaluating you and making sure that you're safe and checking your positioning and checking your vitals. And like, it's a constant deal. Like, we don't just take you back, put you to sleep, and then walk out. I always bring up the analogy of flying an airplane. You know, we are taking off when we're putting you to sleep. Once we're in that maintenance phase, it is a little bit more laid back, and it is not quite as many things can go wrong, but things can go wrong while we're in that maintenance phase of anesthesia. So it requires you to stay vigilant. It requires you to stay monitoring the patient. And then that landing phase is just bringing the patient back down and emerging them from anesthesia. So
I will say that before I assisted you in surgery and any other, you know, surgical experiences I had, I always thought of anesthesia as like, you know, the Wizard of Oz, you know, pay no attention to the man behind the curtain, you know, kind of
Yeah.
like you were in your own world. And,
Right.
but there's a lot of like communication going on between you guys and with the surgeon and you and, you know, back and forth. And so it's kind of interesting to see that from an
absolutely.
outsider's perspective.
I didn't know the anesthesiologists were responsible for maintaining and monitoring the breathing. I thought for some reason that was another specialist that handled that.
You're
for
not,
some reason.
and you're not alone in that. I remember my old roommate when I was going through grad school. He's like, "Wait, you have to go to the school for this long? I thought you just like push a drug and walk away." I'm like, "You just leave them there, no breathing tube, no
I'll be
nothing."
back
And I
later.
had, yeah.
2 hours? All right, cool. We'll be back.
All right, I'll set my timer. Yeah. And that is a question we get a lot. Like, what happens after I go to sleep? And what Travis was discussing. I always like to let my patients know I am back there from start to finish throughout the entirety of the case, or myself or someone else may give me a relief for the day. There is always someone watching over you. You're never alone. We're always here. And it's, you know, it really makes them feel comfortable, because you watch those movies or shows where they see the patient just laying there with like an ET tube, like almost at the tip in their mouth, and there's no one at the head of the bed. I'm like, I promise you, that's not real life. we're here for you.
It's funny because I feel like a breast dog is almost like anyone who's done the flight from Austin to Dallas, where it's landing and takeoff, but the moment you get up, they're like, "Oh, we're now preparing for our descent."
Exactly.
And so, and this is exactly what you guys do, because part of like what Travis was talking about earlier is the preparation. So, like, how long is this going to take? And this is why you're watching, like, oh, okay, implants already going in, they're closing. Let me start like lining up on the medications. Let me start like getting them into a comfortable spot, because you also don't want somebody, coming for a day surgery and then feeling like they have to stay in recovery for 6 hours because we gave them too much medication. It's just, it's amazing how much goes into that, preparation. Just like you've walked around the plane 16 times, same thing. Like, okay, let's see where we're at so we can keep going. Oh, hey, we need to sit them out up a couple times. Let me make sure they're going to stay comfortable a little bit longer, And then even when we're moving people up and down, that's what you guys are talking about, making sure, hey, yep, we can sit that up because that's what the surgeon needs. That's what the patient needs to make sure they get their best result. I'm going to make sure that when they're up and back, like, they get up safely, they lay back down safely, and then I feel you guys, because you guys are, let's make sure nothing shifted when we move. So I think it's all those little things to make sure they get a good experience.
It's definitely more than it looks from the outside, for sure.
Dez, any other things before we jump to our little behind the Bovie segment that we love?
No, I think we've kind of hit some of the really good points of questions individuals have about anesthesia. Like to drop some nuggets.
So behind the Bovie, for those of you that are new to the podcast, is basically where our guests and our team share something that maybe you wouldn't know that happens. So is there anything about anesthesia that people wouldn't necessarily know that you'd like to share with the world, if you will?
Yeah, it's kind of funny that we talk about Duke, because that's where I was the first time I got to shadow someone was when I was working at Duke. And I remember one of the things he told me at the end of the day was, any dummy could just push a bunch of drugs and put someone to sleep, and that's it. He's like, the art of this is the wake up. It is the landing the plane. And over my years of experience, this is probably where it's the most fun, because there's a lot of incisional, work being done, and you don't want the patient to wake up coughing against that thing. You want it to be as smooth as possible. And that is where I really try and do my best to really get that result where they wake up and they're nice and comfortable. And since I've been in this, especially in plastics, it's been so much fun to be able to hone in on that and really keep perfecting your craft, because it's never ending. You're always trying to do something better for the patient, and being able to do that now it's pretty awesome.
That's a good one.
I love that. I would say that people often wake up very similarly to how they go to sleep, which I know sounds kind of odd, but it's very true in pediatrics. When I was in my grad school stuff, I did a ton of peds at the eye center at Duke, and those kids, if they go to sleep fussy, if they go to sleep kind of freaking out, if they go to sleep fighting, they'll wake up that way too. And those people, and it's true in adults too, if they're just super calm and relaxed and nice when they go to sleep, they tend to wake up just super calm and relaxed when they wake up.
That's a good one.
Yeah.
What's nice too is that now knowing that when I see a patient go to sleep and maybe they're like fighting a little bit, maybe they have some myoclonic movements, maybe they're twitching a little bit, maybe they're fighting just a touch, I notice that, and I'll like put that in my hat, and then I'm like thinking as we go through the case, like, can I start to give them other medications that are going to make that a little bit more of a linear, gradual wake up, so when they get to recovery, it's a nice calm process.
That's also to help out our recovery nurses too. They have to recover them. It's nice to help them out, not bringing out a patient, who's waking up kind of swinging for the fences for these nurses, which helps them out too as well. So yeah,
Can we do a little quote of the day?
Let's do it.
Right.
I got one dialed up.
Okay.
I thought this is from Oscar De La Hoya, boxer. It says, "There's always space for improvement, no matter how long you've been in the business."
Boom, that's a good one.
That's good.
Yeah. And I feel like that's us. I mean, we all go to meetings every year. We all talk about stuff. We all do trainings, like
That's why they call it a
practice.
practice.
Look at him.
Sort of.
Drops his own nuggets.
There you
I
go.
like it. I like
welcome.
it.
I'll be here all day.
G-berto, anything? Take us home.
No, I like what Donald said.
That's the only thing he liked.
Very well.
So,
I concur.
whole podcast, I just liked what Donald said at the end.
Celebrity?
Oh no, man. Just be if you do have questions or you're fearful about anything before you go to sleep for anesthesia, make sure you have that conversation. I like when patients confide in me, even if it's 5 minutes before we go back to the OR, and I can answer those questions. I'll take that 2 extra minutes to alleviate their concerns and answer them honestly and put a better game plan together before we head back.
Dez?
Yeah, just to follow up on that too. Thank you all for having me again. I've been listening to this podcast, so I'm glad to be able to be in on it. Yeah, communication. We're here for you, and we want people to know that anesthesia, we are almost your best friends, I guess you could say. Like, we're here for you. We like to spoil you. We like to make you as comfortable as possible, and that's what I want patients to know. Like, we're in your corner, and we're always gonna be there for you. So
For sure.
Yeah.
Well, we can't thank you enough for giving up your Sunday to come hang out with us.
Yeah.
So we truly appreciate it. You have a brand new baby, so
yeah.
appreciate you making time for us and sharing your knowledge with everybody. So thank you all for listening. Don't forget, you can download us wherever you get your favorite podcasts, iHeart, iTunes, Pandora, Spotify. If you want to see all these good looking men, you can also tune in on YouTube. So till next time, we'll see you guys. Thanks. Bye.
All right. Have a good day, everybody.
See ya.